Welcome to the deep dive. Today we're navigating a really fascinating, but sometimes, let's face it, intimidating internal landscape, the human gastrointestinal tract. Specifically, we're looking at its less friendly inhabitants.
Yeah, the ones causing all the trouble.
Exactly. We sifted through a whole stack of sources, articles, research, clinical notes, and our mission today is to boil this complex topic down into something easily digestible, memorable, and, really actionable for you, our future medical pros. Think of your GI tract like this vital superhighway for nutrients, right? But it's constantly exposed to the outside world, and like any busy road, it's vulnerable to unwanted passengers trying to sneak in.
And what's truly remarkable, I think, is how this superhighway, despite just constant exposure to foreign stuff, maintains these incredible defenses.
Right.
So we'll explore how those defenses work and, crucially, what happens when they actually get breached by these tiny invaders. Our goal is to give you not just the facts, but the key insights to really understand, retain, and recall these concepts. We've even got some handy tools lined up.
Like metaphors, some mental anchors, maybe even a few acronyms to help these ideas stick long after this deep dive is over.
Perfect. Okay, so let's start at the beginning. The GI tract's main job, obviously, digestion and absorption. The small intestine is the real powerhouse there. But when things go wrong, it's almost always down to inflammation.
Inflammation, yeah.
Which brings us to our first mental anchor, the inflammation-itis club. That common suffix itisis, it's your immediate clue for inflammation no matter where it pops up.
And if we connect this to the bigger picture, inflammation is basically the body's alarm system, right? Knowing where that itis is sounding, the alarm tells us a huge amount about the symptoms you'll likely see and, the potential causes. These aren't just isolated things. They represent a whole spectrum of patient experiences you'll be diagnosing. So when you hear
Oesophagitis, that inflammation in the esophagus, gastritis, stomach's inflamed, enteritis, small intestine, colitis, that's the colon, and proctitis, rectum inflammation.
And it's pretty common for more than one part to be involved, right? Like gastroenteritis, that's stomach and small intestine inflamed together.
Spot on. And speaking of gastroenteritis, let's just clarify a few definitions that can sometimes get a bit muddled. We'll call these the dizzying Ds.
Okay, the dizzying Ds. I like it.
First, gastroenteritis, that's the syndrome we just mentioned. Nausea, vomiting, diarrhea, abdominal discomfort. Pretty broad.
Got it.
Then diarrhea. Obviously, that familiar symptom. Frequent or fluid stools. But here's a key question for you, our sharp medical student listener. What's the main visual clue in a stool sample that tells you if an infection is just making toxins or if it's actually destroying tissue? Think about that for a second.
Ooh, that's a good one. A key visual clue. I'm picturing it now.
Excellent. Keep that thought. That leads us to dysentery. This is more specific. It's an inflammatory disorder, often with blood and pus in the feces. Usually comes with pain, fever, nasty cramps. Typically affects the large intestine.
So the blood and pus.
That's your answer. The presence of blood and pus in the feces is your visual cue. It signals an invasive infection. Mucosal destruction is happening. That's very different, often much more serious than just the watery diarrhea you get from enterotoxins.
Makes sense.
And finally, enterocolitis. That's inflammation of both the small and large intestine together.
Fantastic.
Yeah.
So we know where inflammation can happen, what it might look like symptom-wise. Now, who are these uninvited guests crashing the GI party?
Good question.
We've got four main categories, right? Bacteria, viruses, protozoa, and helminths. Those are worms.
The big four.
Each one causes its own kind of trouble, with distinct patterns that you, as a clinician, you'll learn to recognize. Let's maybe see them in action with some classic cases.
Good idea. Let's ground this in reality.
Okay, case one. Picture this. You're in clinic. A 32-year-old woman comes in. She's had watery diarrhea, abdominal cramping, a bit of nausea for about 2 days. She just got back from a week in Mexico, enjoyed the street food, drinks with ice, the drill.
Classic scenario.
She says no vomiting, no bloody stools, but she's going like 5-6 times a day, very loose. So for you listening, based on that travel history and her symptoms, what's the most likely bacterial culprit causing her traveler's diarrhea? And crucially, how quickly did it probably make her sick? We'll circle back to the answer.
Good pause for thought there.
But before we get the answer, let's quickly nail down some terms. Food poisoning, that's kind of the big umbrella, right? Illness from contaminated food, whether it's the bug itself or its toxins.
Right.
Food intoxication is more specific. You've ingested preformed toxins that bacteria already made in the food.
The toxin was already there, waiting.
Exactly.
Right.
And traveler's diarrhea is just what it says on the tin gastroenteritis you get during or shortly after travel.
Perfect. So this case, it raises a really important question for clinicians. What causes that distinct onset and those specific symptoms in travelers' diarrhea? Well, bacterial pathogens are the main players here, causing maybe 80–90% of cases.
Wow, that high.
Yeah. And our traveler from Mexico, classic example. The most likely organism causing her trouble is Escherichia coli specifically, enteritosogenic E. coli, or ETEC. It's the #1 cause of travelers' diarrhea worldwide.
ETEC, okay. Got it.
Now, to help you figure out why symptoms show up when they do, let's introduce our time teller trio for incubation periods. This is a really crucial diagnostic tool.
Love a good anchor, time teller trio.
First up, 1 to 6 hours, rapid onset. Think of these as the speed demons of food poisoning.
Speed demons, nice.
This super fast onset is often due to those preformed toxins we mentioned. That's food intoxication. Key players here are Staphylococcus aureus and Bacillus cereus.
Okay, 1 to 6 hours. Staph aureus, Bacillus cereus.
Next, 12–48 hours, intermediate onset. This is where our case 1 culprit, ETEC, often lands. Salmonella species also fit in this window.
Right, so our Mexico traveler fits here, 12–48 hours, E. coli, Salmonella.
And finally, 48–72 hours, delayed onset. This group includes bugs like Shigella species and Campylobacter jejuni. Takes a bit longer for symptoms to show up.
Okay, 48–72 hours. Shigella, Campylobacter. That time teller trio is really helpful for sorting things out quickly.
Exactly.
So back to E. coli. It's a gram-negative rod, you said.
Oh.
And virulent strains like ETEC make enterotoxins and LT, heat labile, and Staph, heat stable. But what about those rapid onset speed demons, S. cereus and B. cereus?
Yes, the quick ones.
They cause vomiting and diarrhea because of those preformed toxins. And here's something really critical for your future practice. Those toxins, they're incredibly tough. They often survive cooking.
That's a scary thought.
It is. So a key takeaway,
Yeah.
just killing the bacteria in food doesn't always make it safe.
Yeah.
If those toxins are already there, they can still make you really sick. That's why proper food handling, rapid cooling is all so important.
Absolutely crucial. Now, moving on, Salmonella species. Gram-negative flagellated rods usually get it from contaminated food or water. The non-typhoidal types usually cause your standard gastroenteritis. But Salmonella typhi, it's kind of got a split personality.
Yeah.
It causes a much more severe systemic illness, typhoid fever or enteric fever. High fever, abdominal pain, often constipation, weirdly enough. Sometimes those classic rose spots on the skin.
Rose spots, right?
And complications can be really serious, bowel perforation, sepsis. So recognizing that difference between non-typhoidal and typhoidal salmonella is vital.
Definitely sounds like it. Now, what about another bacterial challenge, one that kind of messes with our idea of safe food storage?
You must be thinking of Listeria monocytogenes.
That's the one.
Yeah, this is a gram-positive rod with a really peculiar and clinically very relevant ability. It can actually grow at low temperatures.
In the fridge.
In the fridge. Think about it. The place we think keeps food safe can actually be a breeding ground for Listeria.
Yeah.
So it can cause illness from foods you might think are fine, like ready-to-eat meats, soft cheeses, smoked salmon, especially if they've been stored a while. Big risk for pregnant individuals, the immunocompromised, babies.
Very vulnerable groups.
Exactly. And it has a really long incubation period, anywhere from 3 days up to 70 days. It makes tracing the source incredibly difficult.
Wow, 70 days. That's a huge window. So the fridge isn't always a safe haven, especially for some people. Okay, and then there's Vibrio cholerae.
Vibrio cholerae, gram-negative, comma-shaped bacterium, usually transmitted through contaminated water. It can cause a milder gastroenteritis, but it's famous for causing severe cholera, profuse watery diarrhea, often described as rice water stools.
Rice waters.
Leads to rapid, severe dehydration. Management here is absolutely critical. Aggressive hydration, oral if possible, 5E if needed, plus specific antibiotics to cut down toxin production and how long they shed the bacteria.
Okay, hydration is key there.
Absolute paramount. Now, while bacteria are common culprits, viruses are also huge players, especially when you see big outbreaks.
Right, like in hospitals or care homes.
Yeah. Exactly. Let's look at case 2. A 72-year-old woman, she's in a rehab facility after a hip fracture. 3 days after admission, boom, sudden nausea, vomiting, profuse watery diarrhea. And then you hear several other residents and even 2 staff members have similar symptoms in the last 48 hours. She looks dehydrated. Lab stool tests come back negative for bacteria.
Oh, dear. That sounds like a nightmare scenario.
It is. So, for you listening,
Right.
what makes this particular bug so good at spreading like wildfire in crowded places like hospitals, residential homes, cruise ships, especially when the bacterial tests are negative.
Highly contagious negative bacterial tests. Sounds tricky. What's the practical difference for us clinically when we face an outbreak like that?
Well, the most likely cause here is norovirus.
Ah, noro.
It's a leading cause of viral gastroenteritis. Causes something like 3 million cases a year just in the UK. It's notorious for those widespread outbreaks we just described. Hospitals, care homes, schools. And to answer your question, it spreads so well because it's incredibly contagious. Transmitted by the fecal-oral route.
Fecal-oral, right?
And you only need a tiny amount of virus particles to get infected. Makes it really hard to contain without super strict measures. Incubation is usually 12-48 hours. Typically watery diarrhea and vomiting, usually self-limiting. But dehydration support is often needed, especially in the elderly.
And infection control.
Key. Thorough hand washing with soap and water. Critically, alcohol gel does not eradicate norovirus effectively.
That's a huge point. Soap and water, not just gel.
Absolutely. And affected people need to stay home for 48 hours after symptoms resolve to stop spreading it.
Got it. 48 hours post-symptoms.
Precisely. Another important virus, especially in kids, is rotavirus. Used to be a really common cause of gastroenteritis in children aged 6 months to 2 years. Still causes significant global mortality, unfortunately.
Right.
Also fecal-oral transmission. Incubation about 48 hours. Rotavirus makes an enterotoxin called NSP4, which messes with chloride secretion and causes watery diarrhea and vomiting. Fortunately, we now have a routine vaccination program in the UK for babies at 8 and 12 weeks, which has massively reduced its impact here.
Vaccination making a difference there. Okay, right, shifting gears a bit. Let's explore some of those microscopic invaders, the protozoa, that can cause more sort of prolonged issues, especially after travel.
The longer-lasting ones, yeah.
Case 3. A 40-year-old man comes to his GP. He's had intermittent abdominal pain and bloody diarrhea for about 2 weeks. Now, here's the kicker. He got back 6 weeks ago from a 3-month business trip to rural India. No recent travel or sick contacts since then. No fever, no vomiting, but he mentions feeling tired, maybe lost a little weight.
Persistent symptoms, bloody diarrhea, longer incubation.
Exactly. So given all that, what sneaky single-celled organism is the most likely diagnosis here? This one needs a bit more detective work, maybe connecting those longer timelines, the bloody diarrhea.
You're right. The timeline and the bloody diarrhea are huge clues. The most likely diagnosis for case 3 is anibiasis, caused by Entamoeba histolytica.
Entamoeba histolytica, okay.
Now let's quickly run through the common protozoa you'll encounter. Giardia duodenalis, that's the most common one globally, often causes chronic non-bloody diarrhea, bloating, maybe some malabsorption. Think greasy stools sometimes.
Giardia, right, common.
Cryptosporidium species is the second most common. Again, typically not bloody diarrhea. You see it more often or more severely in immunocompromised people. Can be a real problem there.
Okay, crypto and immunocompromised mainly.
Then our culprit, Entamoeba histolytica. Third most common, but significantly it can cause bloody diarrhea. That's a key differentiator. It can even cause complications outside the gut, like liver abscesses.
Ah, so that fits case 3 perfectly. Bloody diarrhea, travel history.
Precisely. And key thing about protozoa generally is that longer incubation period. Often over a week, sometimes much longer, like in this case where symptoms started weeks after travel. That contrasts sharply with the quicker onset of most bacterial and viral bugs. That delayed presentation is a hallmark you should always consider.
That delayed onset and potential for bloody diarrhea really makes Entamoeba stand out in a differential. Okay, moving beyond acute gastroenteritis now, let's talk about some other persistent problems that you'll definitely see.
Yeah, the chronic stuff.
Case 4, 45-year-old man, GP visit, 3 months of intermittent epigastric discomfort. Interestingly, it seems to get better for a bit right after eating. No weight loss, no vomiting, no significant past history, not taking NSAIDs. GP orders a urea breath test, comes back positive. So this isn't your typical diarrhea bug, right? It's a persistent stomach issue. That positive urea breath test is a massive clue. What bacterium is the prime suspect, and how does that breath test actually work?
That's a great clinical puzzle and, super common in primary care. The most likely diagnosis for case 4 is Helicobacter pylori infection, H. pylori.
H. pylori, okay.
It's a gram-negative spiral-shaped bacterium that has this unique ability to colonize the gastric mucosa, the stomach lining, causes chronic gastritis, peptic ulcers, and it's even linked long-term to gastric cancer.
Nasty little thing. And the breath test, how does that nail it?
Right, the urea breath test. It's quite clever, actually. The patient swallows a capsule or drink containing urea labeled with a safe isotope, like carbon-13. Now, H. pylori produces a huge amount of an enzyme called aureus. If the bacteria are there, This urease breaks down the labeled urea, producing ammonia and labeled carbon dioxide, 13CO2.
Okay.
This labeled CO2 gets absorbed into the bloodstream, travels to the lungs, and the patient breathes it out. We collect their breath sample and measure the amount of labeled CO2. High levels mean H. pylori is present and active. Think of its urease enzyme as like its little shield against stomach acid. It neutralizes the acid around it, allowing it to survive.
Clever mechanism. So you detect its waste product, basically, and how do you treat it?
Management is typically triple therapy. That's a proton pump inhibitor like omeprazole to reduce stomach acid plus 2 antibiotics. Usually amoxicillin in either clarithromycin or metronidazole, taken for about 7 to 14 days.
Triple therapy.
Okay.
Got it. Classic one to remember. Okay, now for case 5, which really highlights how our own interventions can sometimes cause problems.
Yes, the iatrogenic issues.
68-year-old woman, 4 days of watery diarrhea, abdominal pain, going up to 8 times a day, sometimes notices blood mixed in. No recent travel, no sick contacts, didn't eat anything dodgy. But crucially, 2 weeks ago, she finished a 10-day course of clindamycin for a dental abscess. No other new meds. So for you listening, imagine a silent saboteur living inside you, just waiting. It only strikes when your defenses are down. What kind of medical intervention might accidentally trigger this saboteur to cause a severe gut infection? You will definitely see this as a junior doctor.
Absolutely. This is a must-know. The silent saboteur here, triggered by antibiotics, is Clostridioides difficile infection, C. difficile or C. diff.
C. diff, right. Knew it sounded familiar.
It's an anaerobic gram-positive rod, and it produces these incredibly resistant spores. Think of them like tiny time capsules.
Yeah.
Allows them to survive in the environment and spread, often via indirect fecal oral routes in healthcare settings.
Spores, so they're tough to get rid of.
Very tough. It actually colonizes the gut asymptomatically in a fair few people. It just sits there quietly. But if the gut microbiome gets disrupted, especially by antibiotics, which is our key trigger here, C. diff can overgrow, produce toxins, and cause nasty colitis.
So the antibiotics wipe out the competition.
Exactly. Other risk factors include long stays in hospitals or care homes, being immunocompromised. Even using proton pump inhibitors seems to increase risk slightly. The presentation can range hugely from mild watery diarrhea right up to severe bloody diarrhea, toxic megacolon, which is a surgical emergency, and even sepsis. It can cause something called pseudomembranous colitis. You see these white or yellow plaques on the colon lining during endoscopy, sign of severe damage.
Wow. So really understanding a patient's recent medication history, even antibiotics from weeks ago, is absolutely critical here.
Paramount. Investigations involve testing the stool for C. difficile toxins, toxin A and toxin B. Management uses specific antibiotics, like oral vancomycin or phytoxamycin. Interestingly, IV vancomycin doesn't work well as it doesn't reach high concentrations in the colon. And strict infection control is vital.
And what about those spores? Hand gel sufficient?
Absolutely not. This is super important. Hand washing with soap and water is essential. Alcohol hand gel does not kill C. diff spores. You need the physical action of washing with soap and water to remove them.
Soap and water. Got it. Another crucial point.
And of course, antimicrobial stewardship, using antibiotics wisely, only when needed. Shortest effective duration is key to preventing C. diff in the first place.
Makes total sense.
Okay, finally, let's touch on the macroparasites, the worms. Often overlooked, but really common. Here's case 6. A 6-year-old boy. Mom brings him in because he's had really bad itching around his bottom, especially at night, for about 2 weeks. She says he's been more irritable, restless at night, waking up scratching. No fever, no diarrhea, no belly pain. Oh, and she mentions his older sister has just started complaining of similar itching too. What's the likely diagnosis? Think common, contagious, affects kids.
Oh, I think many of us might have encountered this one or definitely heard about it. The nighttime itching, the sibling also getting it, screams one thing.
Indeed. The most likely diagnosis here is anaerobius vermicularis, commonly known as threadworm or pinworm in the U.S.
Redworms. Yep.
It's actually the most common helminth infection in Western Europe and the USA. The adult worms live in the cecum, but the female worm migrates down to the anus, usually at night, to lay thousands of tiny eggs on the surrounding skin.
Ugh, and that causes the itching.
Exactly. That causes the intense itching, the pruritus ani. It leads to scratching, eggs get into the fingernails, then transferred to the mouth, or contaminate bedding, toys, making it really contagious, especially within families or schools. Fecal oral route, essentially.
Right. And how do you confirm it?
Investigations often involve the tape test. You apply a piece of clear adhesive tape to the skin around the anus first thing in the morning before bathing. Then stick the tape onto a glass slide and look for the characteristic eggs under a microscope.
Simple but effective.
Yeah.
And treatment, just the child.
No, and this is key. You need to treat all household members simultaneously with an anti-helminth medication, like mebendazole, single dose, often repeated after 2 weeks. Plus, strict hygiene measures are vital: frequent hand washing, keeping fingernails short, regular laundering of bedding and night clothes.
Right, treat the whole house. Crucial public health point there because it's so easily spread.
Absolutely. And just briefly, other helminths to be aware of: tapeworms, toniasis. You get the adult worm infection from eating undercooked infected meat, like beef or pork tapeworms. Can cause maybe some vague abdominal symptoms, nutritional issues, rarely bowel obstruction.
Okay.
And then there's cysticercosis. This is different. It's infection with the larval stage of the tapeworm, specifically the pork tapeworm, Tanias. This happens if you ingest the eggs, maybe from food contaminated with human feces. The larvae can then migrate and form cysts in various tissues, including muscle, eyes, and crucially, the brain. Neurocysticercosis is a major cause of seizures in endemic parts of the world.
Wow, so eating the worm versus eating the eggs leads to totally different diseases. That's a key distinction.
Huge distinction, yeah.
Okay, wow, so many potential invaders, such varied presentations. So when you're faced with a patient suspected GI infection, how do you actually pull all these pieces together? Let's use our shine anchor maybe to think about assessment, symptoms, history, investigations, next steps, examination.
That's a great framework. For history, yeah, you need to be detective. Focus on the time scale, that crucial incubation period we talked about. Ask really specific questions. When did it start? How quickly did it progress? What are the associated symptoms? Is there bleeding, severe pain, fever? How's their hydration? Are they managing to keep fluids down?
Right.
And critically, that social history, recent travel, even if it was weeks ago. What specific foods have they eaten? Any sick contacts, family, work, daycare? And as we saw with C. diff, why is it so crucial to ask about recent antibiotic use or even hospital stays?
Because the incubation for some bugs is long and antibiotics can trigger C. diff weeks later.
Exactly. The incubation can be long, and the impact on the microbiome from antibiotics can completely change the picture. A thorough history is paramount, honestly. It often gives you like 80% of your diagnosis if you ask the right questions.
So really drilling down into those clues we've discussed. And the examination. What are the priorities there, especially if someone's looking quite unwell?
For examination, always prioritize assessing their fluid status. Capillary refill time, skin turgor, check their mucous membranes, heart rate, blood pressure. Dehydration can kill, so that's number one.
Okay, fluids first.
Then a thorough abdominal exam. Check for tenderness. Is it localized or diffuse? Any guarding or rebound tenderness suggesting peritonitis. Is the abdomen distended? Listen for bowel sounds. And of course, examine other systems if their symptoms suggest it. Check for those rose spots in suspected typhoid, for example.
Makes sense. And investigations.
Bedside tests first, full set of observations: pulse, BP, respiratory rate, O2 sats, temperature, maybe a blood glucose. Blood tests might include inflammatory markers like a full blood count and CRP, urea and electrolytes to check kidney function and hydration, liver function tests, maybe a blood gas if you're worried about sepsis, looking for lactate, blood cultures if they're febrile or look septic.
Standard workup for someone sick.
Yeah. And then crucially, stool investigations. Microscopy, looking for ova, cysts, parasites, white cells. Culture and sensitivities to identify bacteria and guide antibiotic choice. Sometimes specific tests for viruses like Norovirus PCR or C. difficile toxin assays. And maybe imaging like an abdominal X-ray or CT scan if you're worried about complications like obstruction or perforation.
Okay, comprehensive. That brings us nicely to management. Once we have a clearer idea, what are the main principles?
Management boils down to a few key things. First, adequate hydration. Oral rehydration solution if they can manage it. IV fluids if they're significantly dehydrated or can't keep anything down.
Hydration, hydration, hydration.
Absolutely. Second, specific antimicrobials, but only if indicated, guided by the likely or confirmed pathogen, the severity of illness, and the patient's own factors like comorbidities or allergies. Remember, many viral gastroenteritis cases don't need antibiotics, and as we said, they can worsen things like C. diff.
Right, judicious use.
Third, public health notification. Many of these pathogens, like Salmonella, Shigella, E. coli, O157, cholera, are legally notifiable. You have a duty to report them to help track outbreaks and protect the public.
Okay, public health duty.
And fourth, absolutely critical, infection control. Isolation, especially for things like C. diff or Norovirus,
Yeah.
using appropriate personal protective equipment, gloves, aprons, and meticulous hand hygiene, remembering that soap and water requirement for spores. This all ties into the chain of infection model, understanding how these bugs transmit. Fecal-oral, contaminated food, water, surfaces is key to breaking that chain and preventing spread.
Great summary.
And just quickly, it's worth remembering other infections can also spread via ingestion, even if they don't primarily cause gut symptoms. Think poliovirus enters through the mouth, replicates in the gut, but then can invade the nervous system. Or Toxoplasma gondii ingests cysts from cat feces or undercooked meat, usually mild but can be severe in pregnancy or immunocompromised people, affecting eyes and brain.
Good point. The gut is an entry point for more than just gut infections.
Exactly. And even things like dental infections decay. Gingivitis, periodontitis, or oral infections like candida, thrush, herpes simplex, Coxsackie virus, they're part of that broader system, often spread by ingestion or direct contact too.
Wow, what a deep dive into the microscopic and sometimes macroscopic world of GI infections. We've covered so much ground, from those speedy food intoxication bugs to the stealthy protozoa, the tricky H. pylori, and C. difficile.
Quite the tour.
We've given you the inflammation-itis club, the dizzying Ds, the time teller trio, and our shine anchor for assessment, hopefully all useful tools to make this stick. Remember our GI superhighway. Understanding its vulnerabilities, its weak points, that's really your first step to becoming an excellent clinician in this area.
Yeah, and if we connect this to the bigger picture for your medical journey, it's all about pattern recognition, isn't it? Recognizing those patterns, the incubation periods, the specific symptoms like bloody versus watery diarrhea, those key risk factors like travel or recent antibiotics, that's what will really sharpen your diagnostic skills and guide your management effectively.
Absolutely. Spotting the patterns.
So as you move forward in your studies, here's a final thought to chew on. We've talked a lot about how the gut microbiome's delicate balance can be disrupted, particularly by antibiotics, leading to infections like C. diff. But what if, in the future, we could intentionally manipulate that microbiome? What if we could use probiotics, prebiotics, maybe even fecal microbiota transplants more widely, not just to treat, but to actually prevent some of these infections? What future treatments might emerge from understanding this incredibly complex microbial ecosystem even better?
Harnessing the microbiome itself? That's
Yeah.
a fascinating thought for the future.